Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Well, welcome everyone to The Pursuit of Health. My name is Reinier Schuur. I am now a visiting fellow at the Center for Modern Health. Joining me today is my fellow visiting fellow, Colleen Smith, who is also an emergency medicine physician, and Jared Rhoads, the executive director for the Center for Modern Health. Now, before handing it over to Jared, I think I should explain to our audience the relaunch of this podcast. The Pursuit of Health was created by Colleen and I initially at Americans for Free Choice in Medicine. And the podcast was dedicated to rethinking American healthcare from a philosophically informed and pro-freedom perspective. And over the last year, we've been working with Jared at the Center for Modern Health, and that was going so well that we decided to join Jared at the Center for Modern Health. And we were able to get the podcast with us and bring it over to the Center for Modern Health. And that's what we're doing today, basically. We're relaunching the podcast. And so, Jared, how about you explain to our audience a little about the Center for Modern Health?
Sure, thanks, Ray. So the Center for Modern Health is a think tank or a policy think tank that specializes in health policy. And we come at this topic from sort of a vision where every person should be able to pursue health as this active and rational project of theirs. We think that is a good ideal to hold. Now, of course, what that means then is you have to ask, well, what kind of policy is compatible with that? What sort of policy ideas either hinder that or aid in that? And that's where we get into where the rubber hits the road is the policy ideas and the premises around them and everything, and the implementation and the whole sort of stack of it. We view where this leads us is to free markets and to freedom as enablers of this vision of health as something that people ought to be able to pursue rationally. And one other thing I would put in right away there is that there's an immediate corollary to that, which is that if we're thinking about how people can be free to pursue health in the best way possible, that also means the people who are involved in the production of health, right? So that includes everything from physicians to other clinical people, all the business people who are involved in coming up with entrepreneurial organizations and business offerings and services and all the rest of it that all fit into that complete that vision, right? And so that's sort of a really high level summary of sort of our thoughts and our motivation here. I'll just say another quick word or two about what do we create, what we're doing, what are the actual products and that sort of thing that we're engaged in making. From the Center for Modern Health, what you can expect is things like this, which is podcasts and these kinds of conversations and moving the ball forward in the policy space. And in the cultural space too. We can get into that more later. But through things like this podcast, also through many articles and writings, that's a big part of it. The writings, if you ask, well, what form do the writings take? That's going to be a broad range. You'll see everything from commentary to studies to articles that have are digging up empirical data and wrestling with that. Policy briefs, anything that we think is helpful in moving the one or more conversations forward in our mission here. So you'll see a wide range of things like that, and we're looking forward to doing it. There's also an educational portion of what we do. We can talk about that if maybe in future episodes or so. But we working with students who are interested in getting involved in this kind of work and possibly going into healthcare, medicine industries, as well as potentially working with people who are already in those industries and working in a professional way already. So we've got some programs like that, either already in existence in the case of the student one, or planned, hopefully, in the case of the professional one. So a wide range of things and products and things to get involved with. So yeah, I welcome our new and existing listeners to this project, and we're excited to get going.
And what we thought we would do for this first episode of the relaunched podcast is to dig into one of your articles, Jared, that has to do with reshaping the debate around healthcare. And the reason why that's important is that you just mentioned all these things that we plan to do at CMH, which involves talking to different people, pursuing different policies, doing different studies. But all that takes place within this wider context of this thing called the healthcare debate. So that's important to grapple with, because if that debate is being held in a particular way, it affects all those other things that we and other people are trying to do. So this is a question to both of you. How should we think about the nature of the healthcare debate right now?
I mean, I think Ray and I both talked about this to some extent on our last season of these podcasts, but I think, and if we're going to talk about your article, Jared, you also brought it up at the beginning of your article too. There's this real sense of the debate that's framed as we just everyone has already made the assumption that something needs to be done about healthcare or to healthcare, and especially in the kind of more partisan world, the question isn't really whether we need to do anything or not, but to what degree should the government be involved? To what degree should someone else be paying for everyone else's healthcare? And I think that you bring this up in your article, and you talk about how we are talking about mechanisms, and we think about mechanistically, how do we drive down costs? How do we um, how do we get doctors under control? How do we regulate hospitals that are, right? I think that now everyone's talking about how hospitals are the driver of all of the costs in healthcare, and trying to point to hospitals as the problem. But you know, there's something kind of deeper going on here, and I think what we really want to do is reframe that and move away from how do we attack each of these tiny little things to what's really underlying all of this, what's going on at a deeper level. And then furthermore, at a deeper level, what should healthcare be?
Yeah, and I think
And
what's interesting is that from a certain perspective, when it comes to fundamental questions like the role of government versus freedom and things like that, there is, in a certain sense, no debate in healthcare. Like that debate, maybe to some extent, it was never really had, but it certainly isn't being had right now. The debate is more a question, like you said, Colleen, of how much government do we want? And you might hear people who are arguing for free markets and for freedom of choice for patients. But just consider how all of that is often being framed, is that those, again, are mechanisms under which we can make more efficient the government regulated system. It's not really a question of how do we expand freedom and individual rights and markets as a matter of rights. Those are all seen as tools that in some ways the government can use to just make the system more efficient. So in that sense, that kind of debate is dead. And I see it as our goal as an attempt to revive that. But I think the only way that you can start and revive that kind of debate and question is that you have to start by unearthing and exposing the premises that frame the healthcare debate as it is currently being had. And that is precisely what Jared does in his article. So, Jared, how about we dive in there and we get into some of those premises?
Sure. Yeah. Yeah. No. As exactly as you say, there's so many different debates going at any given moment. Frankly, it's part of what makes health policy so interesting. I'll give it a nod in a positive sense there. But it can also be really, it can make it really hard to know where to dive in and like where can you be effective? At what point, where's the policy lever that brings about change, and what kind of idea actually brings about change? Um, you know, it, it, it it's probably very multifactorial here. But it is good to sort of step back and, like you said, take a look at some of the premises that are operating in the policy space, and you could say in the culture in some sense as well. Um, I kind of take three of them in the article. The title of the article, by the way, is Shaping Both the Big Debates and the Many Sub-Debates in Health Policy. I've got it printed out here in front of me. And I come in with like three premises that I want to kind of talk about in the article. There are more, right? Like it's not, these aren't the three. These aren't, I'm not making a claim that you can like reduce all of them down to these three, or that these are like three of the definitely most important or something. I think they're three important ones. But the first one, well, not in order, but the first one I think makes sense to talk about here is the idea that individuals can't be trusted to make good decisions about their health. This comes up in lots of different ways. And one thing I'll note too is for this conversation is like for all of these, there's always some element of truth to it, right? And that's what kind of makes it sellable, and then that's part of what gets people to accept some of these premises. Is healthcare complicated? Sure. Do most people know the ins and outs of like clinical medicine? No, right? So yeah, there is some sense in which healthcare is a difficult thing to contend with if you're just a regular person like me, right? From a healthcare consumer standpoint. But where that ends up kind of going too far, though, is if you really, if you really sort of let that idea kind of calcify and start building everything around that idea, is that you end up with a system that doesn't trust patients at all, and puts too much of the emphasis on what kind of system can experts build, and what kind of system can people in Washington, D.C. construct. And they're always kind of looking at minimizing some bad thing from happening, even if it's a relatively rare or low probability thing of happening. And so the fixation becomes on that, as opposed to how can we free up people to act in a way that kind of maximizes their health opportunities and their health gains. We end up playing this game of trying to kind of minimize losses instead.
And I think what should be pointed out there is that this distrust towards individuals as patients being able to make their own decisions extends also to doctors and other providers to a certain extent, that we don't trust doctors to operate as if they were on like a real market, right? And that or like just like a market where other people can start playing a bigger role, like corporations and things like that. So it's something where we think that the judgment of the doctor of what's right versus what things cost should be protected.
I
Yeah.
mean, I think this stems from something that is an assumption or a premise that's pretty deeply ingrained in the medical community, which I think dovetails with this premise, which is that doctors shouldn't consider cost the price of things at all in the decisions that they're making. And so if we set up a system where no one needs to know the cost, then the idea is that that will be better for everyone, because doctors and patients will just do the right thing, with no not without if they don't have to think about how much something costs them. But in fact, there are many more costs than monetary costs, and I think that puts us into a situation where we when we're used to not considering cost at all, we also don't consider cost to life and and standard of living and just time and living pain-free days and things like that we should also be considering, but we just kind of lose the muscle that helps us consider those things when we also don't factor in actual monetary cost as well. So I think it kind of bites us. It comes back to bite us.
Yeah, absolutely. And with the consumers, right? There's sort of like a skill involved with being a consumer that, savvily, can you say that word? In a savvy way, consumes information about medical, options and, is weighing costs and, doing a little bit of I hesitate to say research. I don't mean doing your own research in like the medical way. I just mean like, doing research about what your options are and figuring out, making a good decision about your care and that sort of thing. Like that's a skill that can get lost if we're not trusting people to do that very much, and we're trying to take care of it for them, right? And so that's so anyway, that's one of the sort of premises in this paper. I should say, if I haven't said it already, it's not that we're raising each one of these premises and then giving a full debunking of it either. I actually think we kind of approach and address some of the pushbacks and critiques that are possible. But I actually think you could probably do a full paper on each one of these, and we probably will in the fullness of time. So if these are the kinds of issues that you out there listening to this podcast like to think about and grapple with, just wait, because I'm sure we'll do probably an article on this, right? Let's move. Should we move on to the second one?
Yeah.
Yeah.
Yeah. Another one that we talk about in the article is this idea of insurance coverage sort of being not just synonymous with care and security, but almost like the end all be all of health policy. So much of health policy revolves around the idea of, oh man, if we can just get people covered onto some program. And sometimes this means, if you're talking about people that you think have the means to purchase insurance, well, then this gets expressed and manifested in the form of insurance mandates, right? And now you're required to buy coverage. If for other income levels, it becomes either an actual entitlement. You will have government programs that seek to cover people, or the sort of in between mode of this is that you get people onto a sort of government marketplace in quotes, but then which is heavily subsidized, and again, the thrust of it all is to get people covered, and the idea is like, well, if we can just get people covered, doesn't that take care of everything? And unfortunately, it doesn't. Probably one of the most common things in like free market health policy 101 is to point out that an insurance card does not equate to care necessarily, right? Just having the Medicaid card in your wallet doesn't mean that you're actually going to be able to seek care. You still have to find a doctor who can accept that, and that can be difficult in certain ways. So this is once again, though, this is one of those kind of premises that ends up pushing the whole kind of conversation out there toward a more government driven solution, right? Because if you see this as if you see lack of coverage as such an important problem, and you're on the premise that government needs to address that, you're probably going to be looking to create a program or put people onto a program, as opposed to thinking of ways to make insurance less costly, so that people can go and afford it themselves and buy it themselves, and have more of a direct connection with their own insurance shopping experience there.
I think
Yeah.
what's also interesting to point out to the audience is the way that the first premise that we covered is related to this premise of comprehensive insurance coverage is the kind of like health policy goal that most people take for granted. So, uh, Colin and I had done a previous episode on again this idea that we talked about, that we want to protect both the patients and the doctor's judgment from things like market forces, right? And early on in American healthcare, doctors had this like fee for service model where they essentially had the responsibility to always make the right call, that they would uh, essentially have the responsibility of deciding does a patient actually need this or not, and basically building up their business because they were able to have trust in the community. And the problem with that model is that it couldn't really scale, right? And so they were fighting insurance, but eventually insurance was really the only game in town for how to potentially provide more coverage. And the um, medical profession accepted that because it allowed them to retain this kind of ideal that, well, I just practice medicine, I'll send the bill to the insurer, right? And the patient just shows up to the doctor's office. They don't have to think about what things cost. So it's the expanding comprehensive coverage is a way to kind of maintain this ideal where neither the patient or the provider really has to think about cost, which is I think why it's been so enduring. And it speaks also to the fact that it's not simply something that came out of calls for healthcare being a right from the patient side. Like well before people were making those arguments, people had this ideal that their preferred interaction between doctor and physician where was one where we would have doctors that didn't have to think about costs. And the comprehensive coverage ideal is one way of preserving that.
I think another really important point about this premise is that we have actual data supporting that in fact insurance coverage doesn't equal having a doctor having quality care. And Jared, you mentioned in your article the Oregon health insurance experiment that showed that in Oregon they put a number of patients on Medicaid and a number of patients they didn't fund, and it was sort of a random assignment to Medicaid or not, and they followed health outcomes for 2 years. And while the patients on Medicaid interacted with health care providers more and with the healthcare system more, neither group had better outcomes in terms of actual health. And furthermore, just last year in 2025, and this isn't in your paper, the Milbank Memorial Fund, which is this nonpartisan group that does a lot of surveys on healthcare and publishes statistics on healthcare, put out a paper about primary care and the state of primary care. And they actually found that although more people than ever have health insurance coverage in the US, fewer people than ever have a primary care doctor. And anecdotally, in my own practice, which is largely in city hospitals, so safety net hospitals, I many of my patients have Medicaid, and my safety net hospital accepts Medicaid, but they are assigned a primary care doctor as part of their Medicaid kind of package. And so after they come to the emergency room, I'll try to set them up with primary care, often at my hospital, so that there will be some kind of continuity of the from the visit to the primary care doctor. But they'll have this primary care doctor who's assigned to them, which will make it so they can't get an appointment at my hospital. When I ask them, like maybe to just call that doctor, they often say things like, "I did. The office isn't accepting new patients." But that's the doctor that you're supposedly assigned to. And so now the patients have to go through jump through all of these hoops. And these are usually poor patients, often not English speaking as a primary language, and they have to figure out how to call their insurance company, how to change their primary care doctor, how to get just things that are difficult even for me to do. So, although that's an anecdotal kind of story there, I think it is kind of pointing to the fallacy of this assumption that health insurance means access to health care.
Right. No, absolutely. And what other kind of market would you see that kind of mismatch persistently, right? I mean, like if so many people were willing to, saying that they wanted to purchase something, there would be producers in any other market, there would be producers rushing in to, provide that and everything, but only in a really kind of, centrally controlled system could that really persist for very long. Yet that's been the case for kind of a while in the Medicaid space. Yeah. Uh, yeah. So it is frustrating. The let's see, the third premise there that we can cover that was in this paper. This has to do with healthcare being thought of as like fundamentally different from other goods and services. And as you can tell, like these all kind of dovetail together in various ways and overlapping. In fact, as we were discussing the other two, I was thinking, I wonder if somebody could map this onto a diagram or something. It would be really neat to see some sort of like very highly overlapping Venn diagram of these three and the other half a dozen that you could name that are of this type. These kinds of premises and how they're sort of self-reinforcing once you start accepting them. But anyway, this one that I think is pretty widespread out there, the idea that healthcare is fundamentally different from other goods and services. If you talk to like some real policy wonks, they'll point back to the classic 1963 paper by Kenneth Arrow. I actually don't think he's entirely responsible for this. I think in his paper he was talking about he was mainly just making observations about how there are some differences in between healthcare and other kinds of things that you might buy. And again, sort of like there are some truths to this, right? There's like a kernel of truth to the fact that, for instance, you can't try on healthcare in quite the same way that you can like try on a sweater in a store or take a car for a test drive, right? So there's like there's truth to that. You can't try out a surgery before you commit to it or something like that, right? But at the same time, if you take this too far, which people have done, I think it starts to fall apart though, because there's a certain non-uniqueness to this though too, because we also see for instance, one of the characteristics that is commonly brought up is well, there's an asymmetry of information. Patients know kind of about their condition, but they don't know much about medicine. Doctors, on the other hand, they know a ton about medicine, and so it's and what options they'll have, and so isn't that asymmetry of information something that causes a breakdown? Well, as many people have pointed out, that's the same thing that happens when you bring your car, for most people, that when you bring your car into an auto body shop or your mechanic, most people, especially these days, don't know the ins and outs of how to fix their engine or something that's going on with their car. That doesn't seem to throw that whole industry completely off the rails. So, what exactly, where does the line get drawn then exactly on some of these claims about healthcare being really fundamentally different? I tend to think of this as maybe sort of a difference of degree. Sure, on some variables, imagining a continuum, it's either more similar or less, but overall, it's not such a difference of kind that really requires us to kind of discard markets and go all in on a government solution to everything. Yet it's this premise is held and sort of perpetuated in a way almost to suggest that it should be. So that this is sort of one of those other premises that's really kind of pernicious and pretty widely held out there.
I think you can even use examples in healthcare to kind of combat this. I mean, you can look at plastic surgery or LASIK, the treatment for the eye surgery to fix your vision. You could look at dentistry, which does have there is some health insurance or some dental insurance coverage, but it's definitely more of a dental insurance tends to cover the more expensive procedures, and often you will have to pay for your own cleaning or some portion of your own cleaning and routine dental care. And so there's kind of a difference there in the way that that those kind of health kind of healthcare associated markets in work that shows that you can find other ways to deal with this information asymmetry.
Yeah, I think what's important to point out though is that this view that healthcare is different that you see in certain economic articles and circles and whatnot. It's it's not like that's where that view originated, right? It's not like people thought healthcare is like any other good, and then modern economics came on the scene and pointed out that it was different. People have always thought that it was different, and I think that in many ways, the kind of modern economic analysis of healthcare as a good incorporates a lot of those older views. And while I think it's very important to um, engage with and counteract those economic fallacies with better economics, they're also not enough. I think you'd actually have to go a little bit deeper and point out that no, people have had this view for a very long time. And it's again related to the first premise that we discussed, this idea that a doctor's judgment should be independent from considerations of price. That view has been kind of held as an ideal in medicine for as long as at least Western medicine has existed. And it makes sense, though, if you actually think about how people have thought about health for most of human history. Very often, health is seen as like some ideal state that you'll have in the afterlife, or we had before we came to Earth, right? Like there's like a Garden of Eden where Adam and Eve are healthy, and disease is punishment for sin. So that also changes the way that we think of the people that heal us, right? They're kind of restoring us to this kind of state, this singular state that's the same for everyone. And it's one where, therefore, there's not like all these kinds of differences that you have to contend with. And it's also one where it seems inappropriate for someone to profit off of kind of sacred knowledge to bring you to that state, right? That's kind of like, I don't know, a priest charging you per every confession that you take. It's like that's just like obscene. And I
Didn't
think,
they used to do that though?
well, like with indulgences, yes.
Yeah, yeah.
Yeah, right. Yeah.
But like in the same way that people objected to things like indulgences, that like, yeah, that's a similar kind of objection that people would have to healers profiting too much or taking on a kind of commercial ethos that's just not right. And we'll get into what we think of like the proper view of health, but I think that if that is your view of health, it changes the way that you view healers. And I think that has consequences for all these other premises that we've held. And really like it's an ancient view, which I think in many ways shapes the entire healthcare system and healthcare debate, where we don't want healers to think about cost. We just want them to provide what's right, and cost is a secondary question. It's a question of how we fund them, not how we think they should think about their art.
Yeah. And so, leading off with these three premises that are common out there, you can kind of see how it sort of steers most conversations one way or the other to toward more government control and government directed quote solutions. It's sort of I mentioned this in the article. It sort of becomes like the water in which you swim, right? So the famous David Foster Wallace phrase there. You don't even at some point. I think people don't even necessarily notice it anymore. There's lots of different policy people working on these issues, and sometimes you get almost kind of blinded by dealing with them all the time. And maybe even you start to accept them in some ways. But one of the things we're trying to do here with the Center for Modern Health is really kind of question some of these premises and come up with new and different solutions. um, and also new and different ways of advocating for some solutions that have been developed and are good ideas, right? I mean, it's not like everybody in the doing kind of market oriented health policy, has been putting out ideas that wouldn't work. But sometimes it's an idea that isn't a good idea. Other times it's an idea that's good, but it's not being advocated for in a particular way that's likely to succeed. There are lots of reasons why we sometimes feel like we're in the doldrums of health policy and not making progress on market oriented fronts. Um, to to sort of jump in on some of the ideas that are can be seen as like alternatives to these premises. One is just the kind of the thing that we started with, which is the realization of health being this vision that of individuals pursuing this thing as part of a life well lived. This is a value for people to pursue, kind of like any other value. You might argue that it's more important because it sort of underlies a lot of the ability to pursue other values and live a long and fruitful and healthy life is obviously tied and connected to many other values that you'll be pursuing in your life. But you can think of it in some of the same terms. Pursuing relationships with your doctor in a certain way, and other organizations and services that are part of the healthcare ecosystem and serving you. I think so that's sort of one high level kind of like paradigm shift that if you once you start looking at it as that being the project and trying to get as many people to see healthcare as that kind of pursuit as opposed to this kind of idea of risk mitigation and harm minimization. I think that a more positive view leads to kind of a flourishing of ideas and possibilities, and what are all imagine all the opportunities that we could face if more people were free to produce and pursue those in that way.
Yeah, it's interesting to contrast that with the kind of view of health that we covered before from the kind of uh prevailing view of health, right? Where like health is something that uh your doctor helps bring you back to, right? And I do think that if you think that health is this kind of like ideal state that we have fallen from, that necessarily leads to medical paternalism, right? Because it's this one state, the doctor has the knowledge, you don't, and he's going to help you bring you back to that state. But there is no such state, right? It's for most of human history, our modern standard of health was non-existent, right? Like what it meant back then to like have a healthy life was that hopefully you had like a relatively painless death by the time you were 35 or 40, right? But like you had all these other problems along the way, and you would still be considered healthy by like all the other people, right? Because like most children died before they were like 5 and like all these other horrific things. And uh most of what doctors did was either harmful or they just helped you endure incredible amounts of suffering, right? Um, our modern standards of health are a man-made achievements. They aren't some ideal state that we need to go back to. They aren't some state that we had before the Industrial Revolution. It's something that only became possible after the modern age, which is why modern is in our name, in the Center for Modern Health. It's a new thing. And I think it's also important to point out that what coincided with a lot of this explosion of standards in modern health was using reason to shape our lives to meet our ends, and also the introduction of the profit motive in healthcare with the pharmaceutical industry, which came from the German dye industry and smaller apothecaries. They were selling goods, and they were looking at ways to provide value to doctors, and that's where you get this explosion of new ways of dealing with health that didn't exist before. I mean, like, just consider the fact that so many people today would probably not have survived in ancient times because they have all sorts of um, health problems that made it impossible for them to survive. Now, like, we can make unhealthy people uh, exist and flourish, even though by those standards, like the ancient Greeks might have um, done away with them, like when they were born, right? That's just an
Left them
amazing
out in the
thing.
woods.
Right, exactly. That's just an amazing thing that, like, even if you're unhealthy by birth, we can make it possible with modern technology and innovation to keep you alive and improve your quality of life.
So, given the novelty of our modern state of healthcare, why are we basing the way that we approach healthcare and all of these ancient, outdated ideas of what healthcare means and what doctors do and how patients and doctors should approach health, right? We need a modern rethinking of the ideas that underpin our approach to health and healthcare. Actually, Jared, I think you said this really well. At the beginning of your article, you just said, let me find it. You said health is not something done to you, but not primarily something that happens to you, but something you do. And I think that's a very, very short way of saying, we need to rethink and recapture our autonomy as patients and providers, our independence to pursue health as a value to us and a value we create together.
Yeah, and I think that's the kind of idea. Well, first of all, thank you.
I think it's just a really great way to say it. It's not something done to you, it's something you do.
Yeah, and it's something that's going to be, I think, increasingly true, if I can put it that way, um, as with time. Because in the past you could say, I guess, in some sense, like, this is kind of what Ray you were talking about, like health is luck of the draw, or you hope to be healthy somehow, and then if disaster strikes, you kind of cross your fingers. Maybe there's something that they can do for you, maybe not. In the past, it was not particularly sort of person driven, like it is increasingly going to be today. I think heading into this next, I don't know, 100 years, 100, 200 years of humanity, it's more and more going to be the case that this is like a personal value pursuit, because more and more we will have things that um, are geared toward, like, we're gonna get into like the longevity stuff, but there's going to be like, oh, do you want to try this active thing to extend your life? We're not sure. It's new. We don't know if it's going to work or not. Some of those are maybe expensive, some of them aren't. There's going to be lots of things that become possible in these next, like I said, like 50, 100 years. And the more optional and sort of even experimental that some of those things are, the more it should be a personal call about that. And it's going to be even more impossible to design a, I don't know, government health insurance system that makes that possible for everybody. Some people don't even want it, and there's going to be even rational debate over whether to go down this road or that road with your health. What's your own health philosophy going to be? The more and more it becomes personalized like that, looking forward to genetic kinds of treatments and everything, genetic therapies. The more it becomes like that, the less that this, sort of like old 20th century or even further back model is going to fit. And so, just one more plug for the modern element to this project.
And I think what that also points to, is on the producer side, right? It's health isn't this one thing. It's like it can refer to energy levels, stamina, strength, um, even lots of important differences if you're very sick or terminally ill, like quality of life, being able to do certain things over other things, and which ones you prioritize, right? Like it's not simply like a luxury kind of question to focus on energy levels and sleep and all these other things. Is that those similar differences also exists on the extreme end of health, where you're very, very sick. Like those individual differences really, really matter to people. And I think uh, what that means for the uh, producer and the provider on the other end is that they're thinking of those things, right? They're thinking about how do I help this very sick patient do this particular thing, even though it might be out of the standard like form of treating them, right? Because like they want to do that thing, and like the way that I'm being told to treat them like doesn't actually get them there. And having uh both patients and different kinds of providers and producers think about those things. And I think what else that points to, which I really want to emphasize, is that you need freedom in order to do that, right? Um, Freedom isn't like this luxury thing that like, oh, we get to like have like a little bit of choice in medicine. Medicine and modern health is a product of the human mind that requires freedom, right? It's like no accident that we saw an explosion of modern medicine and innovation following the Industrial Revolution, right? Because there was increased personal freedoms, but economic freedoms, right? And the reason why that's important is because it stands in contrast, first of all, with the ancient view, where health is this thing that exists that like the sacred experts help you back to, and so it's just like a matter of like distributing it, right? And like just making sure that everyone has like a holy healer, right? Um, but if health is something that is created, right, by both the values of patients and producers, freedom is a necessity, right? It's without freedom there is no modern health, and I think in many ways we would have even more health if things were freer, and we're held back by a lot of these ancient views of what health is and how it should be distributed. And I think this is also in contrast with how freedom is sometimes discussed by people who claim to be advocates for free markets, where they again will have this view that like, oh yeah, health is this thing that exists. It's just a matter of how we can get there, and they just think that governments are an inefficient way to get there. Let's use free markets, right? But then it's still using freedom and free markets as kind of like this tool that helps with the distribution of health and healthcare, not as
Yeah,
something fundamental for its creation.
you can see that with how government has tried to kind of harness free market techniques to try to cut costs or improve things. For example, Medicare outsourcing health insurance through Medicare Advantage, and ultimately that just backfires over and over and over again, because in part because it's this kind of weird intertwining of government and private and a private company, but largely because the the incentives are not aligned with those of freedom, of patients making free choices or producers making free choices. They're more aligned with how can we squeeze more money out of the government.
One more thing I would say too, and I mentioned this in the article, is sort of about the burden of proof here. We're talking about the premises that kind of tend to steer these conversations and this policy work in the direction of more government. Well, the burden of proof really ought to be on the people who are advocating for restriction on freedom. Tell us why that needs to be the case, instead of it being the other way around. If you are advocating for, if you think there's such a strong reason why we need a control on something or a regulation on something, the burden of proof really ought to be on you to make that case. We are looking at the value of freedom and free markets. as something that is necessary to bring about this new vision and view of people pursuing their health and people producing the goods and services that make that possible and make it possible for people to thrive as something that's extremely important.
I think one way to illustrate that to people is that questions of how we finance healthcare isn't some like dirty thing that like, oh, we like have to like deal with this and then we can like really just talk about health and things like that. Questions about consideration of cost is what enables you to pursue health, right? It's not like these two separate things where here's how we pay for health and like, oh, like this is how we pursue it. To really take full control over the pursuit of health, both as a patient and as a producer, as a doctor, you need the freedom in order to consider cost and think about how you, for lack of a better term, monetize it, right? It's something where thinking about cost should not be seen as a necessary evil or something to be seen as bad. It's something that empowers us, right? And if we truly see that, then any attempt for the government to tell us like how healthcare should be financed, it will be seen for what it actually is. Like the government making those decisions is the government deciding how I can pursue my health and how my doctor can pursue my health. And that I think will go some way to putting the onus on them that, hey, wait a minute, why do you want to impose this way of financing healthcare? You're interfering with my pursuit of health and my pursuit of health with my doctor.
Well, I think we've had a good conversation. Do we want to wrap it there?
Sure. And yeah, we're gonna have many more conversations like this. We'll have ones where we'll dive into articles that we've discussed before. Others will be diving into things that are happening in the news and all of the above.
So definitely follow us on, you can follow our writing at centerformodernhealth.org. A lot of our writing will be posted there and also updates on uh, other activities going forward.
All right. Thanks, everyone. Till next time.
Thanks.
To stay up to date, subscribe to our show from whatever podcast platform you're listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.